understood. And we are very fortunate to have an international personality on amyloidosis, and we needed your blessings. But band kar do to. So, and Mr. Joel Mandal from California, he has become my good friend. So he's also helping me. He has also joined. And then, sir, formally we will be introducing you with our team. 6 months back only we got together and we had no idea that how support group works in India. So we got together and then some of us took the initiative. And being a public servant, rather few doctors told me to take initiative, and we got together 5 or 6 of us, and we have started amyloidosis support group of India. Paula and her other
Muriel.
partner, yeah, Muriel, they also had been in touch with us, and then ARC was in touch with us, and then your international society, they were in touch. They were also guiding us, and then from California, SAAG, Mary and Dana, they helped us. And then fortunately, I had the occasion of seeing several hematologists for my medical condition. Then Dr. Uday was very kind, and I am grateful to him that he agreed to take over the amyloidosis support group. And because I am also, sir, quite old and sick, so he agreed to help us. And today's awareness program that is being professionally organized only with his support. So he's the one who will formally introduce us, and we are now his baby. He is taking care of us, and probably he's just starting a chapter on amyloidosis. And we are pleased to inform you that I have met the minister with a member of parliament and also the secretary health, and they are considering to start a policy intervention with for amyloidosis, and they are including probably very soon amyloidosis as the rare diseases. And there are already 53 diseases, so this is going to be 54th. And today, Dr. Tulika Seth from AIMS and Rishi Dhawan from AIMS, they had also agreed. And several hematologists and cardiologists had agreed to join once they heard about you. And I don't know, I have no clue that how many will come. But sir, we are very much fortunate. We are grateful to you that despite your busy schedule, you have been able to provide us this patronage, and we want to declare today that you shall be our patron as well for this amyloidosis support group. So we are, I mean, we are waiting for Dr. Uday sir to probably, Uday sir.
He's here. So yeah, you're in, thanks Sadish. You are in very good hands with Uday. So.
To the safe hand, Uday sir.
Good evening, Shaji sir. So, sir, first of all, thanks. And anyway, the welcome part of it or the initial, felicitations have been exchanged. So just that key without any further ado. For the sake of the patients, I'll do it bilingual. I'll talk both in Hindi and English to help the patients out, whoever won't be able to understand English thoroughly. So first of all, we are very happy to have Dr. Shaji here. And today we have just, this is the first session of amyloidosis support group of India. So before Shaji sir gives his deliberations on amyloidosis and the treatment and the future of amyloid, I would request Satish Chandra sir to introduce his team. So Satish Chandra sir, कृपया करके आप अपने सारे टीम मेंबर्स को इंट्रोड्यूस करिए ताकि जितने भी लोगों ने अभी ज्वाइन किया है हमें अभी इस मीटिंग में, सो वो सारे लोग समझ सके कि मतलब आपकी जो मेहनत आज तक हुई है और जिस स्टेज पे आप इस ग्रुप को लेके आए हैं, सो वो लोगों को जानना बहुत जरूरी है, बिकॉज आपके हेल्थ कंडीशंस के बावजूद आप इस श्रेय तक इस ग्रुप को ले आ पाए हैं, तो जो अपने आप में एक बहुत बड़ी हासिली है। सो मैं चाहूंगा कि एक बार आप अपने सारे ग्रुप मेंबर्स को, पूरे जितने भी लोग ऑडियंस अभी ज्वाइन कर चुके हैं, उन सबको एक बार इंट्रोड्यूस करें प्लीज। And also few words about ASGI, how you started it and what all, where all have you reached? So कहां तक आप, किस शिविर तक आप अभी तक पहुंच पाए हैं एंड क्या करने की प्लान में थे और आपने कैसे किया, ये भी लोगों को सुनने में बहुत अच्छा लगेगा। तो कृपया करके आप मतलब ना ASGI और अपने टीम मेंबर्स को इंट्रोड्यूस करें प्लीज।
थैंक यू डॉक्टर साहब, थैंक यू सर। मैं अपने टीम में सबसे पहले अल्फाबेटिकली चलूँ तो अर्पित चोपड़ा जी हमारे साथ हैं। Mr. Arpit Chopra ji is in Australia, and he has been very kind to us, and he has been helping us from Australia. और वो उनका ATTR का डायग्नोसिस हुआ, और हम लोगों ने 5 लोगों ने शुरू किया। उसमें एक अतुल्य पांड्या साहब थे। Mr. Atulya Pandya was the one who last year met me at AIMS, and he is the one who helped me in setting up this kind of self-help idea. It came from him, and then we started interacting, and he's the one who gave me this encouragement to get together. And then Mr. Rahul Nathani, he referred couple of patients that why not you give the counseling to the doctors, to the patients. So it was Rahul Nathani at Max Hospital, and Mr. Atul Pandya, who is ME warrior in Mumbai. These are two people. Then after that, I met Mr. Others, Mr. Madam Neeta Sharma, and 5 of us we got together, and one day we thought that why not to give it a name, और हमने फिर उसमें इसका नाम डाला एमिलोडोसिस सपोर्ट ग्रुप ऑफ इंडिया। फिर अर्पित चोपड़ा जी के बाद धर्मवीर वीर यादव साहब जुड़े। धर्मवीर यादव साहब is also probably a veteran, and he has been encouraging us to move forward. And after that we got connected with SAAG California. Mr. Joel Mendel, he became my friend. We are exchanging notes. He is giving me some books, some reading materials, that how to get out of this suffering, and he is giving some Buddha teaching to me. Then Navodita Seth is our research intern who is working for my NGO. I have a small NGO. Since it had no legitimacy, the Amyloidosis Support Group of India, and we are interacting with ministry and all. So I thought that it will be a flagship program under health for my NGO. Neeta Sharma ji is the caregiver, and she is a class 1 officer of Government of India, an engineer, and she is caregiver for her husband, Mr. Sharma, who has been additional secretary with the federal government in India. And then she will be also narrating her story. Then we have Madam Company Secretary Sriya Bhargav ji, who will be interacting on our behalf with Image. And she is a company secretary. Her husband is a civil servant in Prayagraj, Allahabad. And she has been so committed to taking care of her father that she took 6 months leave, and she has gone through the process of a stem cell transplantation. And she is the one who encouraged me to go for stem cell transplantation. And she helps other people as well, and she is very nicely interacting with everybody. And now we have some Soumyadeep Bagchi Sahab. He is from Delhi, sorry, Calcutta. And like that, Mr. Vishnu Kant is from Madras. And then Asa Gupta is also Madam who is with us. So we are 34 people. Out of 34, we have around 23 patients. Rest are caregivers, and few are. One is professor of public health in Utah University, USA. Another is a pharmacological scientist in India for last 30 years. And then we have total 34 members are there. Somehow we are managing to do the research, and we are bringing out with the help of, we have hired Dr. Jaya, who is a scientist, and we are writing a paper on amyloidosis in India, the situation in India on amyloidosis. So with this background, we are exchanging notes amongst ourselves. We have our own independent set of doctors, like I am being seen by the doctor at Max Hospital, Saket, New Delhi, and AIMS, and of course, Dr. Uday from AFMC, and Dr. Mirza from PGI, Chandigarh. So everybody has his or her own set of doctors, but eventually we reached out to the international fraternity, and then we were not able to manage this group because we had many questions from the specialists. And when we were reading the literature, we saw that Mayo Clinic or any institution in USA, they have the integrated system of supervising the patients, like it's not done in silos. But here, chiefly it is done by the hematologist, and if you have some issue with your organ recovery, you will have to go to the particular organ department. Like if it is heart, then you have to go to the heart specialist. If it is kidney, so lot of kind of not very integrated support system is here. So when we were facing these problems, we reached out to Dr. Uday, and he was very kind that he said that, okay, we will give you a platform. So now we are no more with the NGO. We are now part of Image, and we shall be reporting to Dr. Uday, and we all will be helping him in furthering our agenda for our fight against the amyloidosis. In this background, sir, in 6 months, whatever we have done, precisely we have developed a bond. We are interacting. When we have problem, we are trying to exchange notes, but still we are quite segregated in terms of our treatment. Everybody has his own set of doctors and own set of people. So now, sir, our once data scientist, Mr. Jayant Arya, who will be closely working with Image, he has made a presentation. So I request him to give you an overview of patient's profile in just a couple of slides. And through this infographic, you will have an idea that what is our status.
Hello, everyone. Hello, am I audible?
Yeah. Yes, Dr. Jain, please go ahead.
Yeah. Hi, Dr. Saji. Hi, Dr. Uday. So I'm going to present a data analysis that I've made on the basis of 15th patient profile we have received. So the first slide tells about it's about that 73% of male patients are affected and 23% of female patients are affected. The age group which is mainly affected is 50 to 70, and the type of amyloidosis is AL. 87% of patients are affected with AL amyloidosis. The organ which is mainly involved is heart and kidney with 33% and 33%, and 20% of patients have both involvement in kidney and heart. Mr. Jha, next slide, please. Yeah. So in the year of 2022, most of the patients got diagnosis with AL amyloidosis. The treatment regimen they have selected for AL amyloidosis is 64% of DARA VCD, and 36% of patients have opted SIBO-D. So in next data analysis, we can see that 33% of patients have multiple organ involved, and 23% of patients have opted BMT, sir. That's all. Thank you, sir.
Thank you, Mr. Jain. That was a nice information that you could collate as a patient support group. Yeah, but we as Image are also trying to do on the same lines. So we have collated, collated data of around 280 patients till now from PGI, Army, from Amrita Institute, and from Dinanath Mangeshkar. We are planning to include all the hospitals in the country, and hopefully we'll have larger numbers to understand the Indian biology of amyloid. Now, the major hindrance that most of us have is typing of amyloid. So most of the times it's presumptive in nature. It's not definitive, because in India, currently we are lacking the modality for diagnosing the subtypes of amyloid. So the way we will take forward the patient education program or this interaction on today and in the next meeting in the same week, that is on 26, 4 days from now, is today we will have Dr. Shaji to just give us a brief introduction about amyloid, about the treatments which are available and how the disease progresses and what are the options that we have. And on 26th, we'll have an opportunity of every patient talking to the doctors, where we are going to have again a group of national and international experts, in which we already have around 10 doctors from across the country, from the top institutes of this country, who have committed to participate on that day. So today, I would now request Dr. Shaji, who happens to be the professor at Mayo Clinic, in Rochester, USA, my mentor, my teacher, to kindly elucidate and slightly give details to the patients about amyloidosis and the realities and myths about amyloid. So over to Shaji sir, please.
Thank you, Uday. Thanks, Satish. This is really an amazing effort, especially considering this is such a uncommon disorder. I'm really glad that you could all come together and create this group. And I think working together with Image, it definitely can get a lot more attention. And I think with Uday in charge, you wouldn't have any problems getting things done. So thanks, Uday. All right, what I'm going to do. So what I'm going to do is, I'm going to use some slides which I've used for formal talk. So you don't have to focus as much on the individual details in there. I'm just going to use that more in terms of just going through the broader concepts. I am happy to take any questions in Hindi and respond as well, but I probably won't be very good in giving the talk in Hindi. So I'm just going to stick with English right now. Let me try and share my screen. Uday, can you see this?
Yeah, we can see.
Yes, sir, we can see that.
Perfect. So, one of the key differences between AL amyloidosis and a lot of other things that we talk about is that it's often diagnosed very late. And part of the reason is we often don't think about the diagnosis. And amyloidosis is also, again, a huge family of disorders, right? So it's the only thing that is common when you say amyloidosis is that you have the amyloid protein in one or more of the organs in the body. And the amyloid protein is called amyloid protein just because of the way it looks under the electron microscope with a certain, what we call a fibrillar structure, or the way the protein structure is made up. Any amyloid you take, they will all look the same. Now, at the same time, we know that amyloid can be formed from a variety of different proteins. The most common is the one that was already talked about, which is the light chain amyloidosis. But there are many other types of amyloid. So some of them, one of the common varieties, especially in the West, that we see are the hereditary types of amyloidosis, where there is a mutation of a particular protein that leads to the protein becoming unstable, so to speak, and then it gets converted in the body to amyloid fibrils. Now, the second big category is what we call an acquired type of amyloidosis, in which case you have the most common is the amyloid light chain, or the AL amyloidosis, which is the amyloid protein is made of what we call immunoglobulin light chains. So we all have immunoglobulins in our body that helps the body fight infections. Sometimes the cells that make the immunoglobulins, called the plasma cells, can become abnormal, and it's become almost cancerous, that it increases in numbers without any control, and they make a lot of light chain, which then gets converted into amyloid protein. But it's also important to remember that probably less than 5% of people with a abnormal light chain will develop amyloid. So it's not just a matter of protein being there. There are other factors that we still don't quite understand that allows this light chain to actually become amyloid protein in the different organs. And then we have the TTR amyloid. Again, broadly, it can be because there's a mutation in the TTR gene that leads to the protein being unstable and becoming amyloid. Or more commonly, it is what we call a senile type of amyloid, where in the older patients, for some reason, even the normal TTR protein can get unstable and become amyloid proteins. So clearly, it's not just one disease. When we talk about amyloid, it's basically a family of disorders The only common thread there is that the protein looks similar under the electron microscope or under the normal microscope when you do specific stains like what we call the congruent stain. So with that background, we're going to talk a little bit more in detail about the AL amyloid, and we can certainly talk about the TTR and the other types on a different occasion. So as I said, the biggest hurdle is in making a diagnosis is actually suspecting it. The reason why we don't suspect it often is because the clinical presentation can be, there can be multiple different symptoms, none of which are very specific, right? So you take any one symptom out of this list of symptoms out here, say, for example, shortness of breath, right? So there can be, 20 other reasons much more common than amyloid that can give you shortness of breath. If someone else can have carpal tunnel syndrome, the most common reason for carpal tunnel syndrome is not amyloid. So there are some things which are a little bit more characteristic. So for example, they talk about the macroglossia or enlarged tongue. That is fairly specific. If you see that, then you definitely think about amyloid as one of your top diagnoses. You see somebody with a lot of bruising around their eye, then that make you think about amyloidosis. But the most common symptoms like weight loss, fatigue, gastrointestinal problems, bruising, weakness, neuropathy, heart problems, many of those things are more, the amyloid would be way down in the list of potential causes for those symptoms. And that is the reason why the diagnosis is often made late. The second is, it's not a condition that most people are going to be familiar with. Most of the people, these symptoms will take the patients to their primary internist, or they may go to a cardiologist, they may go to a nephrologist. So if you go to an internist, again, these are not symptoms that the people attribute to a rare diagnosis like amyloid first. When you go to a specialist, there's more likelihood that you're going to end up with the right diagnosis. So if you go to a nephrologist because you have a lot of protein in the urine, it's more than likely the nephrologist is going to do a kidney biopsy and you'll arrive at a diagnosis. Similarly with cardiologists, again, you might end up ruling out some of the common causes first, but eventually a higher likelihood that you will end up with a diagnosis. It is less common that these patients will actually be diagnosed for the first time by hematologist. When that happens, it's usually because they've already been identified as having an abnormal protein in the blood, the abnormal light chains in the blood, what we often call as a monoclonic gammopathy. And as part of the workup of monoclonic gammopathy, you identify that a particular patient has amyloidosis. Otherwise, the majority of the patients we see as hematologists often have that suspicion of the diagnosis already in the picture before they actually show up for diagnosis or for workup. So again, when on the left-hand side, you can see that the immunoglobulin light chain amyloidosis, you can have a variety of different organs. And again, the symptoms patient present with depends upon which organs are affected. And as was already shown by Jayant earlier, there can be multiple organs that can be involved. The most common organs tend to be the heart, the liver, the kidneys, the nerves, and the GI tract, and all of these can have a variety of different symptoms. So the heart involvement can be shortness of breath, heart failure symptoms, abnormal heart rhythms. Liver, it can be fatigue, weight loss, abnormal liver tests. With the gut involvement, it can be difficulty in swallowing, malabsorption, diarrhea, constipation, that kind of symptoms. Nerve involvement often is neuropathy or numbness or tingling. And you have skin involvement, which can present as skin lesions, or you can have the blood clotting involved, which can lead to, again, easy bruising and so forth. So how do we, let's say we suspect that someone has amyloid and we want to see if it is true. The only way to make the diagnosis is to actually show the presence of amyloid under the microscope. And where can we detect the amyloid? If we do in the light chain amyloidosis, if you do a bone marrow and if you do what we call a fat aspirate, which is essentially taking some of the fat cells using a syringe and needle from underneath from your abdomen. And if you do both these studies and do the staining for the amyloid, you can find in 87% of these patients, one or the other of this tissue will demonstrate presence of amyloid. The other 13%, if you won't find anything in the bone marrow or the fat, then you have to do a biopsy of the organ that you suspect is involved. And it could be, again, a cardiac biopsy, it could be a liver biopsy, it could be a kidney biopsy. Now, once you do get the tissue out, whether it be bone marrow, whether it be fat aspirate, or whether it be the organ, the way you make the diagnosis is by a stain that is called Congo red stain. Now, this stain has been around for decades, and in the hands of an expert pathologist, you have a 90+% chance that the person would accurately make the diagnosis of amyloid. Now, the problem with this particular technique is that it has to be done by a laboratory that is very used to doing these stains, otherwise they can be miscalled. And also the pathologist has to be very well trained in that, or be familiar with the condition. Otherwise, again, you can lead to more overcall or undercall of the diagnosis. When you look at the picture, you can see what is indicated as C, that greenish tinge. That is something that is called the apple green birefringence under a special type of microscope. Now, once you show that there is amyloid by using the Congo red, the next step is obviously trying to identify what type of amyloid is this. So for the longest time, what we have done is what we call immunofluorescence, where you can use antibodies against specific proteins to say this is the protein that the amyloid came from. So you could have a stain against what we call a kappa light chain or a lambda light chain. And if it shows only one and not the other, then you know that the amyloid protein came from that particular light chain, which is what we see with the light chain amyloid. The problem with the immunohistochemistry is that it may not always be successful, and sometimes the same caveats that the person seeing this should be should have a lot of experience in reading this. Now, there's also a problem because almost, let's say you take 100 patients with what we call the monoclonal gammopathy of undetermined significance, or who have these abnormal light chains, and you and 100 patients who with light amyloid and the light chains, almost 10% of those patients, the amyloid might not have come from the light chain. So it's very, very important that we actually connect the dots and make sure that which protein came from. Now, the best way to do this is what we call the mass spectrometry, where you take the biopsy, you kind of cut out the area where you see the amyloid and put it through a machine, what we call a mass spectrometer, which can chop up the proteins into tiny pieces and look at the sequence, and then tell you by comparing it to a master library that this is the particular protein that it came from. So with the mass spec being routinely used, now we have about 35 different proteins that have been identified that can actually give rise to amyloid. Majority of them are rare. The most common are the light chain and the TTR amyloid. There's also something called the secondary amyloidosis, which often used to be seen in the context of chronic infection like tuberculosis and chronic autoimmune disorders. But that's become much rare because all these infections and the inflammatory conditions can be better controlled with the medications that we have right now. So now the problem with the mass spectrometry is, as Dr. Uday already pointed out, this is not something that is widely available, but hopefully, through concerted efforts like what the group is doing, hopefully we can develop some of these centers of excellence in India where you can have these procedures available going forward. And I think having 2 or 3 major centers with pathologists who are very expert at diagnosing amyloid, it'll also help with getting a very accurate diagnosis of these patients. So once we know that that there is amyloid somewhere, that we already did a biopsy, we did the mass spec or this immunohistochemistry, and we know that this is light chain amyloidosis, the next step is to identify which all organs are involved. And as was already shown, the heart is the most common, next is kidney, then it's nerve, and then liver, and so forth. And almost third of the patients can have 3 or more organs involved, and another third can have 2 organs involved. So how do we understand, or how do we understand the extent of amyloid involvement? So that requires specific tests, mostly blood tests, which can tell, and urine tests, which can tell us, is there liver involvement? by doing the liver function studies in the blood, urine is involved or not by looking at the kidney function test in the blood and the protein in the urine. You can look at the heart involvement by doing some blood tests, but also by looking at a echocardiogram or a MRI of the heart. You can look at the blood coagulation problems by looking at some specific coagulation studies, and so forth. So each organ, we do a battery of tests focused on specific organs to understand which organs are involved. The reason why we want to understand which organs are involved is because that gives us a good sense of how the disease is going to behave or respond to treatment. So, obviously, as with all other diseases, we want to get a good sense of how the amyloid is going to behave once you make the diagnosis. And there have been a lot of what we call these staging systems, where you can look at a couple of blood tests or 2 or 3 blood tests and get a sense of how patients are going to do. So obviously, the patients in the gray line in the stage 4 disease has very advanced disease with a very significant organ involvement. And those patients, we know the outcomes may not be ideal. And knowing this ahead of time will allow us to do clinical trials and come up with new treatments that can improve their outcome. So what do we do? What is the goal of treatment, right? So one of the things is to kind of shut off the supply of the fuel, so to speak, right? And the fuel for the fire here is essentially the light chains that are being made by the abnormal plasma cells. So the focus of the treatment for AL amyloidosis is predominantly trying to turn off the supply. And we do that by getting rid of those plasma cells by using treatments that are often used for treating multiple myeloma, which is again a related disorder, much more common and clearly a cancer. And not only do we want to make these light chains normal, because that will stop new amyloid from forming, but we also want the light chains to stay normal for a long period of time. Unless it stays normal for a long period of time, the amyloid that is already in the organs will not go away. At the same time, we of course want to make sure these treatments don't have undue toxicity or significant side effects that itself can be problematic. And then, of course, it's not just a matter of reversing the amyloid, but it's also a matter of making sure the organs are supported. So if somebody has significant heart failure, appropriate management of the heart failure by a cardiologist who is an expert at heart failure is going to be as important as the hematologist treating the amyloid itself. So how does, what impact does the treatment have, right? And this is just examples of some studies that have been done where people have shown that, take a look at the blue line, and it's marked as CR, which is called a complete response, which means your light chain levels are completely normal. So what we know is that if you have a complete response, the light chains are normal, your survival, very few people are dying because of the amyloid, at least over the 4 years that this patient group has been explored. Similarly, on the right-hand side, you can see that for the blood test called NT-proBNP, that is a marker of heart disease. If that becomes normal, as you can see at the green line, these patients do well. But at the same time, if you don't get a good response, either the light chains don't go down or the heart markers don't go down, then the patients are not doing well. So we have good markers in the blood that we can follow to examine whether the treatments are actually working or whether we need to do something different. So what are the treatment options that we have, right? So as I said before, the majority of the treatments that we use in the clinic today are aimed at those plasma cells, trying to shut off the light chains. And there's a whole host of different medications, and we'll go through that in a second. The second is to try and see if we can stop this light chains from getting converted into the amyloid, what we call the misfolded proteins. So there are some drugs like doxycyclines, an antibiotic that's been around for a long time, that have been shown to have some benefit, but again, questionable at this point in time. But what the new therapies are looking at is trying to see, can we actually actively get rid of the amyloid that is already in the system? So what happens is if we just shut down the light chains, the body will take a long time for the amyloid fibrils to remove them. And that can be a problem if you have very advanced organ disease. So the interest is trying to see, if, in addition to shutting down the light chain, can we do something to remove those amyloid fibrils that are already deposited in the organs? So one of the treatments that we have done is stem cell transplant, and looks like there are at least one of you who have had a stem cell transplant. It's just a modality that we use in patients with a variety of different hematological cancers. We use it very commonly in myeloma. We know it's quite effective in amyloidosis as well. The biggest problem with this is that the amyloid patients, only about 10 to 20% of patients are able to withstand the rigor of a autologous stem cell transplant. It's a very intense process. So you have to very carefully select people without any significant organ abnormalities. And in the past, almost 20 to 30% of patients may die because of complications of transplant. But that has changed over the years, and I won't go into details of these curves. But suffice to say, if you look at the bottom right, that gray line showing 2007 to 2012 basically tells you that very few proportion of patients actually die of complications anymore. We have become much better at selecting the right patient for the transplant. But the problem, and this is the criteria that we use at Mayo, which includes some measurements of the heart function, the kidney function, the age, how many organs are involved, etc. I won't go into this ones. Let's talk about. So the stem cell transplant is a good treatment. It gives responses that often last for an average of about 6 years or more. The problem is 80% of the patients will not be able to go to a stem cell transplant, either because they are old or because they have significant organ dysfunction from the transplant, for a transplant. So what do we do for those patients? The most common treatment that we use nowadays is the combination of a drug called daratumumab. This is what we call a monoclonal antibody. So this is almost a targeted drug that goes and kind of grabs onto the myeloma cells or the plasma cells that make the light chain and kills them. In addition, we combine that with some other medications called bortezomib, which some of you may be familiar with, cyclophosphamide or Cytoxan, and dexamethasone. And this was a large clinical trial that was done that explored to see if adding the daratumumab to that Cybody or the VCD combination, does it make a difference? And the trial was able to show that a higher proportion of patients actually was able to normalize the light chain levels. And they were able to tolerate the medications well, and the patients actually did much better in terms of survival when patients got the daratumumab. And it didn't really make a lot of difference in terms of the quality of life. So the bottom line is the trials show that the daratumumab, cyclophosphamide, bortezomib, dexamethasone combination is the treatment of choice. Now, knowing that daratumumab is a fairly expensive drug, not everybody can get daratumumab. And in those situations, the combination of bortezomib, cyclophosphamide, and dexamethasone is a reasonable alternative, and will lead to, again, it's still a significant proportion of patients actually being able to get to a complete response. So here you can see 18% got into complete response compared to 53% with the DARA. So it's not a bad option either. Now, another option that have been studied is a combination of drug called melphalan, which is very similar to the cyclophosphamide, and that can be combined with dexamethasone. And here again, you can see almost 33% of these patients actually got into a complete response. So what we generally do at Mayo Clinic is that if you are a patient who can get a stem cell transplant, we usually give 2 to 4 cycles of that daratumumab and Cybody, collect the stem cells. If the patient's already in a deep response, then we often just decide to observe the patients and not directly go to transplant right away. But in patients who want to go to a transplant, we will do the stem cell transplant. Once the transplant's done, the next question is how good a response you have. Because remember, our goal is to get the light chains to be normal. If the light chains have normalized, then we don't do anything else. We just watch them. If the light chains are still elevated and the patient's not in a complete response, then we do additional treatments. And these additional treatments will often be more cycles of the same daratumumab and the Cybody treatment. And then if the Cybody doesn't work, then there are other medications like the pomalidomide, the lenalidomide, both of which are considered to be called IMiDs, and often used in patients with multiple myeloma. And there are a whole host of other treatments that we can use as well. So, so there are many therapies. Not every therapy is going to work for everyone. So sometimes it's a question of trying out 2 or 3 different therapies until we find the one that really works and gets the light chains back to normal levels. But at the same time, we have to have very, continue to manage the symptoms that patients have. This is very important because, the normalizing the light chain is not going to make people feel better right away. We need to reverse some of those amyloid related symptoms. So patients often have heart failure or nephrotic syndrome because of protein loss in the urine. That would means often the significant swelling of the legs and so forth, which means we have to, again, manage them with diuretics or medications that tends to kind of get rid of the fluid. People can have shortness of breath, which also often needs specific medications that can make your heart work better. If they have low blood pressure, we can give medications to increase the blood pressure. If they have heart rhythm problems, sometimes we may even put in a pacemaker or give medications to control the heart rhythm. Patients often have poor appetite, in which case we can give medications to enhance appetite, give motility agents sometimes to kind of help the gut move. If they have diarrhea, then again, medications to control that. Symptoms of neuropathy can be controlled as well with some of these medications we have. So, so I'm going to stop there and see if there are any questions. But the key is, again, making the right diagnosis, suspecting the diagnosis, making the right diagnosis, instituting the right treatment, and then following up with good control of the symptoms and ensuring that the treatments actually work is kind of the key for this particular disease.
Thank you, Shaji sir. If we have any queries from any of the audience, Shaji sir would be kind to take those questions. We will avoid individual patient queries in the sense that if you have any queries related to your disease, your management, we'll keep it for 26, where we have an opportunity of doing that. Let's keep the questions generic in nature, which will help everybody. Kishore sir, आप अपना mute off कर लीजिए, please. We are not able to hear you. Yes, please go ahead.
Hello, are you able to hear me now? Good evening, sir.
Yeah.
Dr. Shaji, my question is very comprehensive talk. Thank you very much. I am basically a doctor, and but I look after management most of the time. My questions are very few questions. First is how to suspect the diagnosis of amyloidosis. That's very difficult.
I think the key thing is, I think as physicians, we always look for the most common explanation for symptoms, right? I think the most important thing is when you have symptoms which cannot be explained by the common things, we just have to make sure that we keep rare things in mind, especially things like amyloidosis. So I think it's just a constellation of symptoms that would point you towards in that direction.
Okay, the other question, one more question is that it is early diagnosis versus late in terms of prognosis. That's my concern. So what's your experience like on this?
On the, I'm sorry.
I mean, if you diagnose amyloidosis at very early stage and
Yes.
when heart or other, maybe nerves involved, or but not kidney or heart is involved, because heart involvement is one area which is, which poses very danger in terms of prognosis and treatment. So if we diagnose at very early stage and versus advanced stage, what is your experience in terms of response of patient to treatment?
Yeah, no, again, remember the specific organ, any given patient tend to have a predisposition for specific organs. So it's not necessary that they always start with one organ and then get the second organ, then get the third organ. Some people may have only heart and some people may have only kidney, and they may stay that way for their entire life, with other organs not being significantly involved. But I think the key thing is, even when you have advanced organ involvement, you just need to make sure that in addition to the treatment directed at the plasma cell, you just have to make sure there's supportive care so they can be, the symptoms can be controlled and the patients can be kept in a stable condition until the effect of the treatment kicks in. And what we often see is that, the treatment starts working, but the organ condition is so far advanced that we just don't have enough time for the treatment to actually have an impact. Now, there are times, obviously, somebody has kidney failure, we can certainly consider a renal transplant. Obviously, hemodialysis is always an option in those patients. In somebody with advanced heart disease, we have done cardiac transplants and then followed that up with a stem cell transplant. So there are ways to support the patient through that phase as well.
Thank you. Thank you, sir. Thank you so much.
Yes, Satish Chandra, sir, please go ahead.
Dr. Saab, actually, Dr. Saji, we have many questions for you, but probably we have sent you a profile of those 15 patients. And my request now, Image has collected more data, and we have got a researcher who is MPH, who is doing some kind of analysis that how many of us have side effect from different kind of dexamethasone or different kind of medication that are being given to us. My question is that we wanted to develop some standard operating procedure in India. Like sir had seen me in FMC Pune, he gave me some opinion. Some other hematologists I went and they gave me some opinion. I am being seen by AIMS Delhi. They said that you go for a stem cell transplant, and 35 infusions of Dara I have taken. But still my situation, the heart echocardiography I have done. Dr. Sudi wanted me to do it, and there is no system of understanding whether it is progressing or regressing. So, with the new diagnostic tools that Dr. Uday was telling will be soon introduced, our request is that can you, sir, Amyloidosis Support Group of India has made the Secretary, Government of India, and they are considering us also to declare a mall policy for amyloidosis. So in the given situation when your fraternity in India is getting so much attention and they are noticing so much of problem, and people are at margin, sir, as you have rightly said that unless the treatment is timely done, even if after diagnosis, it might transit into the multiple myeloma, which is a very dangerous situation. At the same time, my friend Dr. Kishore is saying that if an organ recovery is not getting better, then hematological recovery and organ recovery that has to go simultaneous. So, sir, I mean, do you have some kind of Mayo is the best? Can we have like Image and Amyloidosis Support Group of India, which is going to be managed by Image only now? So can we have some kind of best practices of Mayo, which can be introduced not only for us, but across India, sir? It is my 6, 7 cardiologists last year I had seen, and they said you have myocardiopathy because of your age, your pumping system, it doesn't pump properly. So you relax, you don't take a stress, and you will be working, you will be like this. And then I was done EBUS, and EBUS was done twice, and then somehow I pursued myself. I had persuaded the doctor, and then he took out the tissues, and then Congo Red was done, and then my heart was, biopsy was done. We don't have expectometry in the entire country. So my request will be, sir, you are also the international president for the association. Can we be helped in India in getting such diagnostic tools? Like many of us who have gone a stem cell transplant, but they are still suffering with some kind of infection, and there is a continuous botheration. And we do not have access to a doctor all the time. So I will request now Image that on 26th, if he can give us some kind of assurance where we don't disturb the doctor, but there should be question answer, some kind of situation where as a patient, if we register ourselves with the forum, I mean, with this platform, then we are able to be heard and we are able to be addressed, because this is a new disease and it is as deadly as cancer, but we do not have, sir, and we have to a struggle in finding doctors for different specialty. So my question is summarily based on the experience of running this platform. Every individual has his own. Like some of my friend Rohit, his father had endocrinological problem. Jayant Arya, who said his father had the diuretics problem. So we changed the doctors changed the medicines. So we have lots of information input, as you have said, bioinformatics and other statistics. So based on that,
थोड़ी देर में
we
फोन
have
करता हूँ, एक मीटिंग हो, थोड़ी देर में करता
actually, sir, my question is that how do you help us in going further from here? Because we all are very new with this kind of platform and this situation, and we are very fortunate that Image has agreed to help, and you are the best in Mayo. You are the internationally known personality. Vaisali madam had also addressed us. So you all from India are helping us. Now you can give us some assurance, sir, today that how to proceed further in addressing this serious situation, which is a big mental and physical problem for us.
Yeah, no, I think, there are a lot of, in terms of guidelines, I think I'm going to defer to Uday. I think this is where having many of the doctors in India come together, and Image is a great forum to do that. Many of those guidelines that exist already can be adapted for the Indian situation. And I think, again, a lot of these things is getting the adequate exposure and people getting to know about it, and some of the advocacy work that you're already doing with the government will clearly help getting the resources. But Uday, I'll turn this to you in terms of what the options are.
So, sir, as you rightly brought out, so what can be done, or what we are actually already planning to do, is we are having an executive committee meeting a day before this amyloid support group meeting on 26th. So we have a 25th executive committee where we are actually trying to answer these queries and bring out some sort of image document, consensus document about a broad outline. But I totally agree with what Dr. Satish Chandra was bringing out, because it's a patient perspective. But as a doctor, I totally empathize with this condition. And in most of the places in the country, we don't have a nephrologist, a cardiologist, and a hematologist working in tandem to look at the problem together. So that is something which we need to evolve and develop over a period of time. Some centers of excellence where the team comes together. We have some sort of amyloid clinic, which both PGI and Army is trying to start off from the next year onwards, wherein on that particular day, we have all the concerned specialists coming together and spending 1 to 2 hours, depending upon the patient workload. So that's number one. Number two, as far as answering the questions to the queries of the patient, we already, Dr. Satish, we already have that platform for the myeloma patient, where the patients, they log into our Care for Myeloma and the Image website, and we answer those. So over a period of time, with this chapter coming up of amyloid, we are hopeful that we will also have the amyloid patients' questions, queries, and their voices being heard by the doctors, and people, whoever have time, can actually try to answer those. Now, as far as the last point, that is different managements or different treatments at different places are concerned, because amyloid is a multi-systemic disorder, so the same treatment does not really, it's like one shoe does not fit all. But at the same time, I agree that some broad consensus is required. So the best part about the Image is we have got the physicians or hematologists and oncologists from across the country, and we do cross-talk. Like in your case also, we should not generally give individual examples, but there are a lot of physicians who spoke to each other, who talked to each other, tried to reach to some sort of consensus about how to go ahead. And that part of it is actually being done for many difficult cases or many patients where the diagnosis is in a dilemma. So yes, by including an amyloid chapter, that can be done more formally. So I think these are the few things which we can actually take it further. And Dr. Chaji also happens to be an Image executive member. So we all will come together, the international experts and the national experts, and we will design a framework of how to go about for answering these queries, non-medical related, of trying to help out the patients of amyloid over the days to come. So we are hopeful that we are, there's a definitely a positive light on the opposite side of the tunnel, because the way you people have really come up in the last 6 months to 1 year, and the amount you have achieved, that itself is a proof of concept that actually you people can do a lot more. And with the advocacy that you people are doing, and by God's grace, if it gets included in the rare diseases group in the country, so that itself will help lots of generations of patients in the future. So with that, I think because Dr. Shaji has to go for the hospital rounds, so we will keep these questions for further. So I have even some questions on the chat box also. So we will answer these questions in the next meetings to come. This is not the first meeting or the last meeting. We are going to have a series of meetings at regular intervals, and we will discuss with both Dr. Satish Chandra and the members of the other ASGI how frequently we can have it, and we will have it that way. But I would like to thank Shaji sir actually for sparing his time early in the morning and trying to come and share few insights as far as the amyloid is concerned. Thanks a lot, Shaji sir, once again. And I hand over to Dr. Satish Chandra for just giving final few words of vote of thanks before we close the session. Sir has to leave in another 2 minutes. So,
Saji sir, I have been writing to you so many mails. First, forgive me for that.
No, that's okay.
But I could not digest the joy, and I got overwhelmed that why you agreed, Vaisali madam agreed, Dr. Uday agreed, everybody agreed to help us. So we were thinking that we are going to win the victory against, and then ministry is also positive. So everything, the combination of factors during Navratra, today is Mahaastami. So wishing you and your family very happy Navratra, and to all the members who have come. And even Mr. Joel Mandel, who is an American, I give you very good wishes, because today is a very auspicious day for us. So with this, I only, sir, urge that please don't leave us. You have given us a big hope. Take us to Mayo Clinic, all of us, and so how you are treating the patients, at least few of our ASGI members, and train us so that in 28 provinces, we could further build the capacity. This new disease, sir, my friend is sitting here. He is also a retired commissioner, Saral Singh, and Dr. Kishore himself. He took me to his hospital, ILBS, and the best of the physicians, they could not understand this disease. So this is wrong to say, sir, that doctors, they do not know, they know. But here, sir, the awareness has to be enhanced in terms of hospitals, in terms of medical institutions, because it is a very limited knowledge. So this is my request. And we have no words to express our gratitude to Image and to you. I mean, we are speechless. So from the core of the heart, we are very much grateful that you all have agreed to handhold us at a time, and it gives us hope that we will survive. And my wife has a last question, that what should be the lifestyle for a patient? Because I sleep very late, get up very late, so she is always angry on me. So she wants to hear from you that what should be the lifestyle for a person like me. That's it.
Nothing specific. It's something healthy.
and stay
Thank
happy.
you, sir.
All right,
So,
take care. Bye.
Thank you, sir. Thanks a lot. With this, we close the session. Thank you.